Okay, so good evening, everyone. Thank you for joining us in Let's Talk Melanin session. And today we are going to talk about dermatological condition in different skin color. But let me introduce myself first. So my name is Tunprasert. I'm a lecturer at Brighton University, and I'm also working in my own private practice as well. So Amor, would you like to introduce yourself?
Hi, my name is Amor. I would have qualified in UK at University of Brighton initially in 2013, and then I completed my master's in 2016 in podiatry with diabetes. I am practicing in private practice in Barbados at the moment.
Okay, Meghana?
Hi everyone, I'm a student at University of Brighton. I'm in second year and I'm doing the bachelor's undergraduate degree.
Okay, Ada?
Hello, my name is Ada and I'm in my third year of podiatry undergraduate degree at Queen Margaret's University in Edinburgh.
Okay, and Sibo?
Oh, hi, my name is Sibo. I'm a second year BSc student in University of Brighton.
Okay, I mean, we would have James joining us as well, but unfortunately he is unable to join us today. So it's just us five for the time being, but hopefully James will be able to join back with us in the next Let's Talk Melanin session in May, I believe. Okay, so should we get started then?
Yeah, let's do it.
Go ahead.
Okay, so I would like to begin by saying that in today's session, we're not looking to teach anyone anything, but hopefully you will learn something by joining in with our discussion yourself. Okay, and I'm just putting here a chart. Not sure if you've seen this chart before. It's a fit practice chart of a skin type, and just to point out that the skin condition example that we will be using in this session is from light brown skin to down to medium, moderate brown skin, dark brown skin, and also deeply pigmented dark brown to black skin as well. Okay, and let's get started. All right, so now what we're going to do is we're going to do a little bit of guessing game, and hopefully the audience at home can join us in our guessing game here as well. All right, so let's start with these two pictures. Okay. What do you think is wrong with these feet? Can you describe something that you see, or what do you think they are?
Possibly pigmentation due to skin damage.
Okay, which one? Which one?
Oh, I'm not sure. I don't want to.
Amor, would you be able to maybe share a little bit more? These are the cases that Amor have seen back home in Barbados. Okay.
So I'll just give you some context. This patient came in. She is not diabetic, but she has a history of having cardiovascular disease. So she had a stroke about 5 years ago. She gets a lot of pain in her feet at night, particularly on the left side. Clinically, to touch, her feet go from warm to cold to her toes. And to get relief at night, she has to sleep sometimes with her legs over the side of the bed. Does that give any more indications to what you guys think it could be?
Just give me a
It's a vascular problem.
Yeah.
We need the audience to help our students here a little bit. So, what do you think, Amor? Are they right in thinking this is like leading to maybe like more vascular problem?
Yeah, it's definitely a vascular problem. So although the skin is pigmented, you can see that the left foot is a lot darker than the right foot. So though sometimes picking up certain skin changes can be difficult in darker skin, comparing one to the other is a pretty good baseline or where you should start. If one kind of, because you can see, or maybe not very well in this photo, but she has some tan lines with the shoes she normally wears. Being in Barbados and it always being summer, it's warm. So people usually wear toe-out shoes. So there's a little bit of a tan line from her shoes, but you can see towards her toes, especially on the left-hand side, on the dorsal picture, her toes are a lot darker than her toes on the right-hand side. Underneath, because the skin is paler, you can pick up discolorations a lot faster on the plantar side of the feet. And that's where it becomes a little bit more distinct as to what's happening. The reddish color you can see distinctly on the left-hand side, her left, if you're looking at the picture on the right-hand side, especially towards the toes, the tips of the toes. And feeling her feet, pedal pulses very, very weak on Doppler, monophasic on the right-hand side. On the left-hand side, sorry. On the right-hand side, they were biphasic, but they were low pitch. So she's clearly having breast pain at night due to arterial insufficiency. And she came in randomly because she wanted some advice on shoes because her feet were hurting her so bad, especially when she sleeps at night. But shoes in this instance is not really her biggest issue. So I forward her on to see the vascular surgeon.
Yeah. Can I ask a question, actually, Amor? I see that on the right foot, there's like a line that is whiter in color. Is that from the shoes? And
Yes.
that's why, okay. So that's kind of like the untanned part, and then other color around there, other tan color.
It's the discoloration. So yeah. So she, at night, her discomfort, her ischemia is a lot worse on the left hand side. And she, it doesn't always connect with them that her pain is associated. To explain that your pain is associated with your circulation is quite difficult. So her thing is she thinks it's the shoes. So she came in for shoes. But then to explain that it's not and then go through having to refer to other persons and what's not, it's a bit difficult.
That's very interesting. What about the color on the plantar aspect? I see that there are, the red patches on the first MTPJ area and also around the arch area as well. How did it look in person?
When she raised, the longer her feet were up like this, the more red and dusty it kind of became. The discoloration that you can see in her arches, hyperpigmentation in that area, that is quite common in darker skin complexions as they age. So that is not usually pathological at all. I see that quite often. Once they start to get into their 70s and 80s, this lady was, I think, 85 or something like that. So that area is quite common for it to be that kind of splotchy and, in the general midfoot areas where I'm talking about. Underneath her shoes were atrocious. Sorry about that. Her shoes were really, really bad and really hard. And I think that area for her is where she puts a lot of pressure when she's walking. It's a pressure point on her foot. So that part of her foot was particularly irritated. But the skin wasn't actually broken or anything like that.
Okay. Do you guys have any questions for Amor at all?
How is she doing now? Do you know?
No, well, she hasn't. This picture was fairly recent. I think this is maybe 2 weeks ago. So she's waiting to see a specialist. So she hasn't gotten to see him yet. And I kind of have to chase up behind her regarding that because in her head, as I said, although you've been through it and you explain and everything, she thinks once she gets shoes, the whole problem is going to go away. So I need to follow up with her and her GP to see if she actually goes on to have the vascular studies done, because I did send her to have segmental pressures, circulation tests, to see what's actually happening. And my concern is because she has a history of cardiovascular disease, that we don't want them to be any kind of acute obstruction or anything going on, to actually at least ensure it's not anything like that. But yeah, I need to follow up with her. I think she has a follow-up appointment in about 6 weeks, but she was supposed to go see the vascular surgeon before then.
I don't know about you guys, but have you seen this in practice so far as a student?
No.
No. I think I've only ever seen 2 patients in with maybe a six Fitzpatrick type in my 3 years.
Right.
So I think it does depend on, for example, the area that you live in, and what communities live within that area. However, this is quite helpful because you never know where you're going to practice.
I'll be interested to hear UCL, is it East London? Do they still have the podiatry program?
Yeah.
Right. I'll be interested to know if they get a better demographic of people coming through because of their location. I know as a student, one of the things about training in the UK is that when I came back to Barbados, although I work in a diverse clinic and we do have different races and stuff living here, it's predominantly Black people. And learning to pick up different skin changes and stuff, even with, especially in arterial insufficiency, where some of the signs of infection are not as overt as if the person had good perfusion in the lower limb. It is a learning curve. And the more you see, the better you get. And it's useful to have some person who's an experienced practitioner working with you. I don't think any university right now in the UK, you get adequate, if you're going to practice in a predominantly brown or Black skin community, I don't think you can be trained as well as you would be if the school was maybe located, like, in the actual country. But once you start seeing it often, you kind of get used to it. It's one of those things where experience really is more of a teacher than anything else.
You learn from your experience, definitely.
Yeah.
Should we move on to another photo example then? So we have the next one here. What do you guys think? What do you pick up from this photo?
Possibly hemosiderosis, is it?
And there's your champagne presentation, isn't there?
Do you remember this one? Oh, sorry.
Yeah.
Go on, Amor.
Yes. He is on his left side. You can see that he has on a sock. That's actually a compression sock. So he has venous disease. This is a type 2 diabetic. He also has a history of cardiovascular disease. What this photo doesn't pick up actually is that he has venous ulceration on the medial side of his leg. So he came in because his foot was particularly hurting, really painful. Usually doesn't hurt. Why is it hurting now? Kind of thing, because he's neuropathic and all that. And when he came in and he took off, rolled up his shoulders, he has lots of, well, I say lots of. If you look carefully, you will see that the area is very red. He had rising cellulitis, very painful to touch and palpate all around the ulcer. So he had cellulitis happening secondary to his venous ulceration. So we had to send him off to have IV antibiotics. So he had to be hospitalized, I think, for a couple of days. And then he was discharged and we followed up management in the clinic. So things to look for, although it is a dark complexion, you can still see a tinge of red. I think you can all see that, right?
Yeah.
More importantly, you look for the other clinical signs. So you can see that there's hemosiderin staining in the lower third of the leg. Aside from that, if you look towards the toes, unfortunately, I kind of cut off the toes. But the skin looks dry, it looks pale, it looks ashy, what we call ashy. And that's because he has a reduction of arterial circulation as well. So he basically has chronic peripheral vascular disease. He has had bypass, I believe, in this leg. Before that was a couple of years ago because he used to live in England actually. But he came in and he has chronic ulcerations and recurrent ulcerations, mainly because he doesn't wear the compression stockings. So we get him in, we get him healed. He goes off, supposed to use the compression daily. Then he starts off very good and then he kind of tapers off. And then he doesn't exercise and then he's back. So I've been seeing him over the past maybe 4 years, trying to get him to go have venous, the stripping of the vein, because it's one particular vein that he's having issues with. But because of his age and because he owns a farm, he doesn't want to take the time off work to go do it. So, it is working with patients as well. There are a lot of psychosocial things that you have to take into consideration. I think I had him this close to going and having the surgery, and then COVID happened. And now
what surgery do you mean, Amor?
Venous stripping. So because so if he were to have the damaged vein removed, I think it would at least stop how recurrent he is in terms of breakdowns, because he will probably have a breakdown at least twice a year. So, to me, that's too often, especially when things like cellulitis and infection and stuff can happen, and the older he gets, he's been getting away with it more and more, but the older he gets, the more complicated it's going to become. So just thinking long term, I
mean, I find this one interesting when you first sent this photo to me. Sibo, you mentioned about hemosiderin, right?
Yeah.
And do you guys remember how the textbook might describe the color of hemosiderosis?
Brown deposits.
Yeah, so it's brown, like brick-like color deposit. And look at this photo. It's not brick color like the typical textbook description, is it? Yeah, but that was really good that you could pick that up straight away, Sibo. Have you had an experience with seeing this before?
I have seen it, but not in like darker skin.
Oh, okay. Yeah, coppery brown color. Okay, should we move on to the next one? We got still quite a few more examples to go. This is a different case, right, Amor? I think this is a different one.
Yeah.
So
this guy came. Oh, sorry. You guys can have a go first.
Well, initially I thought maybe it was some sort of reaction there, maybe it was something atopic, but we know it's not.
Well, this guy came in, and his concern was this dry skin he was having around one of his feet, which he tried scrubbing with, those foot files that have like the metal foot files. So he was trying to scrub it off, and nothing that he used worked. He had the venous surgery 15 to 20 years ago because of ulceration on his leg. But subsequent to that, he stopped using the compression stockings and the compression hosiery. So what we're actually seeing here is, again, some hemosiderin staining, but more importantly, the lipodermatosclerosis that can happen subsequent to that. So as I had to break it to him, the more you scrub this, you're actually going to make it worse because you're actually going to damage the skin. And there's no quick fix. He didn't want to hear that part because, he came in for this to go away. He wanted me to scrape it off and he would walk out the door with beautiful legs. So, to break it down to him and explain what's actually happening and the process it will take for him to reverse this, he wasn't very happy about. But yeah, this is what it can look like. I think we had another photo.
I think we have more photos, so let's move on. Yeah.
There you go. So it's kind of a little bit more obvious on this side of the leg, I think.
And I think I have another photo. This is still the same guy, right?
Yeah, that's the same guy. So you can kind of see from all angles what it looks like. Any thoughts? According to what you guys would have read about lipodermatosclerosis in the textbooks?
For me, this was the first time I'd seen an example in a Fitzpatrick skin type 6 or 7. To be honest, I thought this was the most interesting photograph to me, really, and a wonderful resource.
Personally, if I saw this photo without seeing these two, just this one, I might not be able to pick anything up just from looking at this ankle. Maybe the slight shininess from the skin around the ankle, but the rest, I might not know whether this is a typical skin color for the patient, maybe, for example.
Yeah, but he automatically, his other leg, I should have taken a photo of his other leg because the other leg is now starting. So I should have actually taken a photo of the other leg as well. So you could see how it looks initially and seeing it initially, if you're not familiar with it, you would think that it is maybe a fungus or something like a contact dermatitis or something like that. But that's where the history comes in very important because knowing that he has a history of venous insufficiency kind of helped me piece together what was actually happening here. And that's why sometimes you can't just look at a photo in isolation or don't just look at the feet in isolation. They're attached to a body. So you need to hear what they have done or what they have been doing or not doing to kind of get an idea of what's happening, as well as the length of time it's been happening. Now, if it was a contact dermatitis or something like that, it wouldn't be going on now for a year or two, it would have gotten, it would have, manifested faster or progressed or whatever the case may be. So history is very, very important when analyzing patients.
Definitely. Let's move on to the next one. Let's have a look at this one then. I think anyone should be able to guess this. Hopefully. What do you think?
Yeah, it's got to be gangrene, hasn't it? Because of the necrosis.
Yeah. So she came in because she was concerned that her toe was going a little dark at the tip, and then you have to try to explain it's not going a little dark, that's actually dead tissue there. So I threw this one in just to show that although the skin is dark, some things are very obvious still. As dark as you are, you're still going to see gangrene coming up. And in persons like this who were at home just thinking it went a little dark, this patient was a diabetic and she'd actually lost the other leg before due to arterial insufficiency. On the island, we don't have a great vascular team. We only have a cardiovascular surgeon here, one cardiovascular surgeon. So endovascular surgery is not something that is routinely done in Barbados. So when you have advanced arterial insufficiency, there are not many options that you have. So for instance, she would have had a previous above knee amputation procedure in the wheelchair. And she was put on aspirin, just to thin the blood to help. But within 2 years, this is happening to her other leg, to her other foot. So yeah, again, history is very important. And one of the things or one of the gems that I took away from university was persons with ulcerations, persons who have amputations are not healthy. healthy people heal. So from the time you start having chronic healing issues, it means that systemically you're not well. And those patients are extremely high risk. So what could be a simple nick? Because I think how this whole thing started was, I think someone in her family had cut her toenails and maybe just had nicked the side or something. And then it led down this road because they didn't pay any mind and she was showering and everything like normal. And we just went down the road of gangrene.
Am I right in thinking that the toenail is gone as well?
Yeah. So I think it's kind of progressed. It had progressed to that point where it had gone under the nail. The nail had lifted away and that kind of.
And am I getting some redness from the skin as well?
Yeah, and that's the whole arterial insufficiency side of things. So they usually describe a reddish dusty color, usually in arterial insufficiency. So you can see here that unfortunately she doesn't have another foot to compare it to, but you can see that's very slight redness in the skin. Photos aren't always the best either for that, but yeah, there is some there on the forefoot in particular, across the metatarsals and into the midfoot. You can see that redness happening. Next time, videos may actually work out a little bit better. Make a mental note of that. So we can do like capillary refill and that kind of thing. So you can see that as well in darker pigmented skin.
So you compare, rather than looking for red specifically, you compare the difference.
Yeah, between on the other side or to the rest of their body. And if you look carefully at this photo as well, you can see that she has another abrasion on the tip of the approaching the sulcus of the
fourth toe. Yeah. Very interesting. Okay. And next one we have, this is, I have to say, this is a condition which I've never seen before. Is it quite common in Barbados, Amor?
Beaches. Once there's beach, there's larva migrans. So this is probably something you won't come across as often in the UK. And that's because, or you may get it with patients. This is where history comes in again. A patient presenting with this, having come from vacation, overseas, a beachy vacation. Larva migrans is basically an infection that you pick up from dirty sand, basically. So like when dogs poo in the sand and that kind of stuff, you get infected. It is extremely itchy. So these patients normally would use topical antifungal creams and stuff before they actually present in clinic. But it does migrate and get worse. In this photo, if you look carefully, you can see that it started interdigitally here, and it has gone up underneath her second toe, and then it's starting to come down just below the metatarsal, the first metatarsal. And if you look at it very, very carefully, you can almost see like stuff moving in it. It's quite interesting to see. But
there's stuff moving inside.
Yeah.
What kind of stuff?
I guess it's larva migrans, so that would be the larvae moving around. But yeah, I part it on to dermatology, and that's important in knowing to when to refer. We are foot specialists, but sometimes we do need to refer because she needed to go on oral medication to treat this condition.
Yeah, so I mean, there's still a chance that, I know it's COVID and all at the moment, but if people go on holiday somewhere else abroad, been walking in the sand and come back with this kind of foot problem, if you've never seen it before, you might not know what it is.
The first time I saw it, I've been working out for about 8 years. And the first time I saw it was this happened last year, I think in like August. So yeah, it's not very common, but it does happen quite often in sandy areas. Or another thing that happens locally is if people have construction of their house, you use, I'm not sure if the UK used it, but you have like sand that they use to mix the concrete and stuff outside. And if they have it lying around and then they have like pets and stuff and then they use it and not wear a appropriate shoes, you can get it transmitted that way as well.
Very interesting, this one.
I think somebody was asking how you treat it.
This one here.
The larva migraines. How would you treat it? What are they given orally? I think.
There are. It is an anti. Give me 2 seconds.
Sorry, I'm going to.
You put a more on spot here.
No, they're Forde. I know the trade name, but not the generic name.
Okay.
So you can go on to the next one. I'll just tap back.
Okay, that's fine. Let's move on. Okay, so I think this is still photo from Amor, but it's in a lighter brown skin color. And it was before and after debridement. I assume, Amor, I didn't ask you, but I assume.
It was. So what I was trying to get over in this one is hyperpigmented spots. So, melanomas are often thought of once you see a hyperpigmented spot, but this one was a little bit of a more simpler case. It was just callus with extravasation. And this person is of Indian descent. So not as dark as some of the other cases you would have seen earlier.
And I mean, do you think in terms of extravasation, does the appearance and presentation look different as well in a darker skin color to you? From your experience, because this is lighter brown color, right? But what about in a very darker? Yeah.
I don't think so. I think this, because it's on the plantar side of the foot, it is not, because even in the darkest complexion, correct me if I'm wrong, we don't go significantly dark on the plantar sides or in the palm of the hand. So you are more likely to pick up extravasation easier. And I guess too, another thing that is a key thing to note is it's on a weight bearing area. She does have hallux rigidus, so that joint really, her first mat doesn't move. So that's why she's toeing off through her, trying to toe off through her interphalangeal joint there and getting that callus there.
Yeah, one thing I pick up from our conversation so far is about knowing the history of the patient, isn't it? Even if it's something new that you may have not seen before in different skin color, if you know the kind of like other characteristic of that condition, you might be able to guess that maybe it is this one, make an educated guess.
Yeah, and that's where history comes into play a lot, especially with darker complexions where things may not be as obvious as in a lighter complexion. History is everything. Sometimes you can do a history and not even look at the person, and you can kind of picture what they're going to tell you is going on with their foot. So yeah, make sure for students, I would encourage you guys to get a detailed history. And if you are fortunate enough to work in a diverse clinical setting, it is useful to know and use these stipulations for privacy carefully. Make sure you're ticking all those boxes, but photograph things as well, because sometimes you do forget, and if you have it in your phone, among all your selfies and other pictures, it's good to make reference back to it just to familiarize yourself with it and to know what you're looking for. But as I said, once you get into clinical practice and you see it more and more often, you'll get it gets easier.
Okay, so I think that's all of the example you gave me, Amor. I think the next one is from the journal. That one of the journal that Ada filed for us. Do you want to talk a little bit about this, Ada?
Well, what we have here is melancholia, and this is something that we see in Fitzpatrick skin types, especially 6, 7, yeah, the last 3 skin types. What I wanted to say was that we always have to be careful to differentiate it from melanomas. And I think there's specific things we can look at. But we'll notice that with people of darker ethnicities and coming from certain parts of the world, it's actually a natural phenomenon. It's idiopathic and it's harmless. However, I think it's important to just, be aware, as I said, look at your medical history. If you see anything there, you sort of follow the ABCs for any sort of change there. That's all I can say
Yeah.
about that now. But what I will say was, looking for resources to put the presentation together, I was struggling to find examples of actual feet. Okay. And I think this is where the discussion is sort of heading to. As we continue in our professions, we're looking for resources for darker Fitzpatrick type skins, and it's very difficult to find them. And especially because we're podiatrists, we're looking for, we want to see feet, we want to see toenails. And I found it was quite a struggle to look for resources. But I feel that this is a topic that's been ongoing for some time in healthcare.
If I just interject here, one of the things, especially in darker pigmented skin, that I have found is a lot of, sometimes I will see something that looks very similar to this presented in the toes, and it's perfectly normal. It's just part of the natural aging process in darker complexion, similar to the photo I was showing you guys earlier, where they get on the soles of their feet and then the palms in their hand, they just get hyperpigmented spots. It's nothing wrong. It's not cancerous or anything, but what caused that? There's no research that explains what that is. I guess because no one has taken the time to research it. It happens. You know it happens. Well, if you work with them, you know it happens, and you become less alarmed. But there are a lot of hyperpigmentation, lesions is one of those things that I don't think is very well documented in the available literature. That explains why or tells you what it could potentially be, unfortunately, or thus far, I should say.
I mean, when I was a student, almost 10 years ago, is it 10 years ago? Probably it is. I went on a placement at Lewisham area, in Lewisham. And because of the patient population I had seen before I went on that placement, I never seen anything like it before. So when I first saw this condition in a darker skin patient, I was like really panicking. Oh, what is this? Was it like, melanoma? Should I be concerned about this? Do I need to do urgent referral? And so on and so forth. So that was my experience. And, throughout the year, I've learned that, as you have explained, it is a natural occurrence, but I still feel like that kind of education and research side of thing hasn't changed much in the past 10 years.
No. And it's bad because, especially for new podiatrists graduating, it's difficult, especially if you don't have an experienced practitioner in the office with you that you can kind of bounce ideas around with, or can just quickly ask a question. You kind of have to learn as you go on. I was very fortunate when I finished that I came back to Barbados and I worked with an experienced person. So, the transition was a little easier. But if I had come out and have gone completely into private practice, working on my own, I would have probably misdiagnosed and sent a whole bunch of these persons down to dermatology for this testing, and it would have been completely uncalled for. But as I always say, when in doubt, though, it's better to be safe than to be sorry. So, if you are unsure about something, do carry it on. But one of the things I always say as well is compare both sides. See if what you're saying on one side is happening in the other. And chances are, if it's bilateral, then it may be just, aging, part of aging.
Yeah. Okay. And I think we have one last example here, which is subungual malignant melanoma. I mean, what do you think of this example?
It's quite obvious that it's malignant, isn't it? You can tell by the image that, yeah, it's definitely not benign.
Yeah.
This is where history comes in as well, and looking, because this could easily have been a really bad bruise from a new pair of shoes that you decided to go hiking in. So, yes, we know because we're trained and we're experienced to know what to look for in terms of the asymmetry and that kind of stuff, in terms of the pigment. But to someone else, they could just have seen it as a really bad bruise. So again, history is very, very important.
Yeah. And I mean, I think one of the signs that they describe in literature when we talk about subungual malignant melanoma is about the bleeding. Bleeding as in not what's it called? Blood bleeding, but the color bleeding from the skin underneath the nail itself to more proximally. And if you look closely at the melanonychia, you would see that the color actually stay just in the the nail area. It doesn't go into the sulcus area at all. And when it's in the in the case like this, it goes further into the skin area, as you can see here. So I think this is our last example, really. And I mean, we've touched upon Ada mentioned this a little bit, but let's talk about our experience in finding or trying to find all these photo example for this today's session. I mean, thanks to Amor, we have had real case photo from Barbados, but if I don't know more and we haven't had any contact out there, would we be able to find all these examples?
I mean, it's been very challenging to find sources, and if you find something, you have to pay for it. So it has been a bit of a nightmare.
Yeah.
I mean, Ada, you spent quite a lot of time trying to find photos for this session, didn't you?
Well, yes, I had to do a small presentation on a cardiovascular condition, intermittent claudication at a university a couple of weeks ago. And I wanted to have a look at some of the nail pathologies. And I thought, well, why don't I just, present with different Fitzpatrick types? And it was a real struggle because I think, first of all, we've got certain resources like Dermanet. And yes, there are some examples there. But again, I'm looking for feet. I want to see toenails. All right. So it got me thinking about that. And I think last year there was a doctor who did a pamphlet called Mind the Gap, which was just even talking about certain conditions and disorders which presented on darker Fitzpatrick skins. And it's quite a short one. And he's always saying you can add to it. And I felt that, oh, well, maybe there's a problem here. And I believe that there was a systemic review that was done last year in the States as well, which mentioned that when we come to examples of Fitzpatrick type skins for sort of 6 and 7, in some cases, there's not even a picture to present. And sometimes you will find a Fitzpatrick type skin of 6 and 7, but it's only showing a very sort of rare disorder. When we're wanting to look at things like atopic dermatitis, psoriasis, eczema, and so it's really opened up the discussion. I think a lot of other health professions are also kind of in the same boat. So I think by preparing yourselves to go into the profession, you have to sort of keep up to date and relevant. And this is an area maybe that, we could go into in terms of, maybe doing a bit more research.
Yeah. It helps to have a friend in Barbados.
Definitely, Amor. Okay. Just want to point out that the resource that you mentioned is this one here. If we can have a screen back up. Okay. So this is the Black and Brown skin website that you can go and have a look at different type of, presentation on the skin that are in a darker Fitzpatrick scale. And as Ada mentioned, you can add to this. You can see there's a button here, submit your image here. One other thing.
Always make sure you ask for consent, please, everybody. Consent.
Yeah. Definitely. I assume consent there, but yes, definitely ask for consent. And I think one other thing that I'm kind of like mindful of when you search online trying to find photo is that if you find some random person posting photo and saying it's this condition, and you don't know the credential of that person, can you trust that it's that condition that person is saying? So, you kind of like have to look at published evidence or, trustworthy website, that kind of thing. So, and some of the published work are behind paywall, which means not everyone can access them. So it's like kind of this loop of problem a little bit. And another interesting resource that I think worth mentioning is if you go to that particular country, if you can have a slide back, please. Have I lost it? Sorry, let me share screen again. There you go. Okay, so if we look at the journal that is from that community, for example, this is Thai Journal of Dermatology. You see that they publish evidence, case report, including photos of that particular skin color. And I think, I can't vouch for all of the journal because this is from my country, Thailand. So I can say that you can go have a look there. But I'm sure there must be like Indian Journal of Dermatology, I don't know, South African Journal of Dermatology and things like that, which could be an alternative option in terms of resources as well. And even though these journal might not be as high ranking in terms of scientific evidence, but it still give you that kind of like case report level evidence that you can go and look for resources there. And there are some other resources that you can have a look as well. But we did discuss this, that as Ada mentioned, some of them, if they have darker skin example, then it's on rare condition, it's on the fingers rather than toe, and all sort of things. Yeah, so...
Just to go back, the person had asked about the treatment of the larval migrans.
That's my lecturer, by the way. That's my lecturer, Amor. Sorry. That's my lecturer who asked.
All right, okay. So I could only remember that it was called Zentel, the tablets that she was taking, but it actually contains albendazole. Is the active ingredient, if that helps anyone. But it is an oral medication, and we don't prescribe. So, as I said, the dermatologist would have been the person who put it on. But Zentel is the brand that we get here locally. But there are lots of other medications that persons can take.
Yeah. Okay. So, I mean, is there any other thoughts that you would like to share at all?
I'm going to finish up by saying that the search continues, and I've got another suggestion. Another suggestion is I found the University of Northampton has a UK website, and they do work with Dermanet. And they may not have the photographs you need, but they've done some interesting reviews. And there's one I'm looking at the moment, which was looking at the racial differences of atopic dermatitis. So I'll certainly put the link up for that, and I think it's free for everybody.
Okay. Yeah, and I think this topic is being picked up quite a lot recently, isn't it? And I think that COVID might come into play as well, because there's the COVID toe and COVID skin presentation that then, it's snowballing from there, and other movement that's been going on. So hopefully we'll see more evidence coming out in the next 10 years. Maybe we can have some more collection of examples that we can look at, that kind of thing. And I mean, before we move on to our last part, which is a recruitment for the next session, I would like to ask the audience if you have any question, and especially if you want to ask Amor here, who's been in Barbados practicing in the past 10 years, right, or less, Amor? About 10 years.
Just about.
Yeah. Who? Are you with us, Amor? Are we losing you? No. Okay, so do you guys have, does the audience have any question at all? No? Okay, that's fine. So let us move on to the last part, which is a recruitment for our next session. Can you remind me again when is our next session? Is it 20th something of May? Let me look at the diary.
25th of May.
Yes, 25th of May. So if I can have the screen back up, please. Okay, so basically in the next session, we are going to talk a little bit about, our thoughts and discussion on the future of BAME podiatrists. And we're looking for more BAME podiatry students to join our discussion next time, in addition to our lovely 3 students that we have here. Hi, so if you're interested, and if you would like to join us in further chat in the future, drop Michael a message at Tomorrow's Podiatry. And what we'll be doing in the next session is we'll be exploring BAME student experience, and these 3 lovely ladies are going to share their own thoughts and current experience and aspiration for the future, and as well as concern. Okay, and then we'll have Amor joining us again as well, right, Amor? And hopefully James as well, who will give that kind of a flip side perspective, whether we can help addressing concerns. So we would like to have more students joining us, so drop us a message if you would like to. Okay, so is there anything else? If not, thank you very much, everyone. Thank you for joining us, with sharing the experience, discussing tonight, especially like massive thanks to Amor for giving us plenty of, excellent example photos and cases. And I think with this kind of things, it's just the more you see it, the more experience you become at it, right? So it's the matter of finding and being able to share more and more examples on this. Okay. Well, thank you very much, everyone. Have a lovely evening. And I think we have some video about the next session on Tomorrow Podiatry coming up. All right, that's it from us then. Have a lovely evening, guys. Take care.
Thank you.
Bye.
Bye.